So tell me a little bit about prostate cancer awareness. It was announced this morning that Al Roker from the Today Show was diagnosed with prostate cancer. Tell me a little bit about the awareness that you work on.
Certainly. Thanks for allowing us to present some important information for Men's Health Month, which is November. Prostate cancer is really two sides of the same coin of breast cancer. Roughly 230,000 men and women each year are diagnosed of their respective diseases, and roughly 30,000 men and women, unfortunately, each year die of their diseases. Women have done a much better job promoting breast cancer awareness, and with their push, there have been positive changes for less radical treatments with improved outcomes. Men have been babies, mainly because of the side effects of prostate cancer treatment, which we call I squared, standing for impotence and incontinence. No one wants to do that. And then the US government challenged the validity of PSA screening. So for a while, after 2012, there was a big drop of men getting screened, which is resulting in a big rise now of men presenting with late-stage disease. From what I understand from Al's comments today about his prostate cancer, he wasn't getting regular PSA screenings, went in and had a very elevated PSA level, and then he did the right thing. And before any biopsy, we encourage men to get a prostate MR. This is like a mammogram, just the way we use mammograms to detect breast cancer in women. Now we finally have an excellent tool to allow us to visualize the prostate and determine if the gland may harbor cancer or not.
And how exactly is that done?
So prostate MR is a standard MR. We like to do it at a high field strength magnet. It doesn't have to be. And we inject a small amount of MR contrast agent. It's called a multiparametric prostate MR. And we use a standard PI-RAD scoring system to convey our relative confidence whether the gland is normal or harbors disease. If we see a suspicious spot, we can recommend to the urologist to do a fusion biopsy and hit the areas that are concerning. And by doing that, we're increasing the detection of clinically significant cancer while also reducing the number of men who can avoid an unnecessary benign biopsy. So MR is really key and pivotal to allow us to improve decision-making with prostate cancer.
And you mentioned before a PSA test. What exactly is that and how does it get done?
Well, it's a simple blood test. So when you go in for your annual physicals, we recommend that all men over 50 should get a baseline PSA. And if the PSA level is less than 1 at initial screening, the man should take comfort that the likelihood of them developing prostate cancer in the next couple of years is very low, as long as there's no nodule detected on physical exam. So the threshold of an abnormal PSA now is around 2.5 to 3, and we look at the velocity. If it's going up quickly, that we're more concerned that it could be cancer, but unfortunately, infection or prostatitis can also cause an elevated PSA or be a false positive test.
And if they do get a false positive test, what should they do? Should they just still be careful and watch just in case, or should they just breathe a sigh of relief?
Well, they should discuss that with their physician. And if they're concerned about an infection, many times they're treated with antibiotics and they repeat the PSA. If the PSA is staying elevated, then the next step is the prostate MR. And the beauty with prostate cancer, unlike breast cancer, is that there is low-grade, low-risk cancer and high-grade cancer and intermediate cancer. So for men with low-grade, low-risk disease, many people recommend doing nothing. We call it active surveillance or watchful waiting. If they have small volume of what we call grade group 1 or Gleason score 6 disease, no treatment is necessary. But before MR, the urologist wouldn't know if there was anything more suspicious in the gland, and they would frequently recommend prostate removal, which for many men would have been overtreatment.
Good to know. Good to know. And I've seen here that there's also some focal therapy options. What exactly is that? And is that an alternative? How does that work?
Excellent question. So before, the only treatments available for men were watchful waiting, surgery, or radiation. And surgery is really optimal for men who have moderate volume of intermediate grade disease or high grade disease that's contained to the gland. If it's spread outside of the gland, some people feel that surgery has a role, but then you would need adjuvant radiation and maybe hormone blockade. But hopefully with improved screening and MR, we're going to find more men with the modest volume of intermediate grade disease. And just like women pushed for breast conservation lumpectomy instead of removing the entire breast, we're now able to provide a focal therapy option for men who wish to reduce the side effects associated with radical surgery. So the focal therapy options is called HIFU, which stands for high intensity focused ultrasound. And with the TULSA device that we use, it allows incision-free, precision-guided, real-time heat mapping of the prostate gland. We heat it to 55 degrees Celsius, which kills the tumor and the gland, and they go home, and their tumor is removed and killed. And for most of the men, over 85% of the men, there's almost no side effects. So we're really thrilled that this is a new revolutionary treatment that may help the majority of men.
And you said 85% no side effects. What about the other 15 or so percent? What are their side effects?
Good question. The side effects frequently are just some problems with urinary control because the men go home with a catheter. That's removed in 7 to 10 days. But when you compare the side effects of focal therapy with TULSA compared to the side effects of surgery or radiation, the side effects over a 2-year TAC trial was less than 2%. In other words, there was no problem with bladder or bowel dysfunction, and the sexual function issues were maintained in over 85% of men, which is much higher than the other types of prostate cancer treatment.
Good to know. And yeah, and are all men qualified for this, or is there a certain stage of cancer where they can't have this done?
Well, there's some exclusion criteria. If a man has a hip replacement, it creates too much artifact on the real-time MR heat guidance. If they have a device called GeroLift designed to treat prostatic enlargement, that disqualifies them. Or if they have large calcifications, the heat source bounces off that and it's not as effective. But for men with large volume of low-grade disease or modest volume of intermediate grade disease, they should all be candidates for this technique.
Yeah, I never would have thought that a hip replacement would not qualify them. Is there a reason? Is it because there's something artificial in them,
Well,
so to
no,
speak?
the MR is very sensitive to metal, and the metal of the hip creates significant artifacts, so we're not able to measure the precise heating that's required to have accurate treatment for focal therapy.
Gotcha. No, that makes more sense. I never would have thought that a hip replacement would have that much impact for something like that, but you learn something new every day. And I thought I wasn't going to learn anything today.
Well, the other important thing is, as Al Roker pointed out, Black men, unfortunately, are disproportionately impacted with prostate cancer. They have a higher incident rate. In other words, they get prostate cancer more than other ethnicities. And unfortunately, there's frequently delayed screening, so they present with larger volume or higher grade disease. So what we really want to alert men to do of all ethnicities is to talk to your doctor about the benefits of prostate cancer screening with PSA tests. If there is something suspicious prior to biopsy, get an MR so that we can identify exactly what's going on. And if you do have cancer, please know that there are options depending on your specific disease stage and grade, and you should discuss those options and make an informed decision.
Now, you said most men 50 and older should be getting these tests. What about the younger men? Because unfortunately, younger men can also get cancer. So should I start looking at a younger age if they feel something, or?
You raise an excellent point, and just as a parallel, the movie actor from Black Panther died of colon cancer at a relatively young age. He died before the incidence of screening was recommended. So we do recommend that for men who have BRCA genetic mutations and other high-risk family factors, they should consider getting screened starting at 45.
Good to know. And is there anything else you would like to add before I let you go?
No, we think it's important that men become more proactive and not be afraid to have appropriate health screening. They should learn how to fight like women to get improved outcomes. And if they have any questions, they can find more information on our RadNet webpage that I'm sure we can provide for you.
Yes, remind us where that webpage is, and are you guys on social media if that's what the kids are using these days?
Yes, they are. It's mriprostate.com, and radnet.com will have links to our prostate support web pages.
Lovely. Thank you so much for taking the time today, Doctor, and I hope you have a wonderful weekend.
Thank you so much for letting us get the word out. Bye-bye.
You're welcome. See you soon. Bye-bye.